first webinar of the Pediatric Academy, Spine Academy of India. It's a nascent or a new organization, but it's got the best brains who do, pediatric spine in the country. And though we say it ourselves, we can tell you that this is a non-profit and a pure academic body. And as you can see, we are, pushing forward with some of the topics that are, very, very deformity or very pediatric spine oriented, but are not been covered in our curriculums or even in our regular discussions in our spine formats throughout the year. And we hope to delve on such topics through the year, and we will have face-to-face meetings also coming up. I'm glad to tell you that we've had a superb response, because I think our topic and our speakers are stellar. And without wasting much time, let me hand over to tonight's host, Dr. Amit Jhala from Ahmedabad.
Thank you, Abhay, for a nice introduction of our society and what we intend to do in the future. So our first meeting or webinar of the Pediatric Spine Academy is on physical therapy in adolescent idiopathic scoliosis. And as you know that this is a part which is quite neglected or new for the Indian subcontinent. And we have got a great two speakers for this first webinar. And I would say that both are one of the most experienced and speakers that we have. We have got Dr. Amy Sbihli. She has got more than 18 years of experience exclusively treating scoliosis. And she has got more than 15 years of training clinicians on how to apply BSPTS methodology or RIGO concept in treating the scoliosis. If I just introduce her, she's just passed her from the University of Michigan for an undergraduate degree. And then she did her postgraduate degree from Washington University Medical School. And at present, she is a North American regional manager and teacher for RIGO concept, BSPTS, that is Barcelona Scoliosis Physical Therapy School. And she is a co-owner of BSPTS North America RIGO concept, SOSORT Education Committee Chair, and founder and clinical director and therapist for Spine Academy Physical Therapy in Boston, USA. So she is very well experienced physical therapist in North America. And to accompany her is, I welcome Dr. Amy there. And to accompany her is Tarju Shah. She is known to at least me in this part of India. And she has passed from India and then went to US. And she is doing specialty in pediatric physical therapy. And she is the owner of the Gray Matters Pediatric Therapy with more than 8 years of experience in treating patients with various neurological conditions, pediatric orthopedic conditions, and various genetic disorders. And with a diversified experience and certification in the RIGO concept, she has passed level 1 of the RIGO concept. And probably Amy is her mentor and guide, right? That's right.
Yes.
Right. Good. And so she is also having outpatient clinical settings in the renowned pediatric hospitals like Texas Children's Hospital based in Houston, Texas. So with this introduction, I think we'll not take much of the time, and I'll hand over for a great talk by Amy. All yours, Amy. Please start.
Thank you. While I'm opening up.
And we are joined by the Asia Pacific trainer, Rebecca Harding, everyone. Yeah. On the RIGO concept. Yeah.
I was just going to share that myself. Let's see from the beginning. Here we go. All right. So thank you for having me. I understand that it's a holiday today, so your diligence to studying on your day off is very commendable. So happy holiday to you. I have a disclosure that I work for RIGO Concept and practice this method, so definitely a bias in my knowledge and training. So we have this historical timeline of knowing about scoliosis for a very long time. The coined name idiopathic scoliosis started or was defined by Kleinberg in Sweden in 1922. And shortly after the initiation of the X-ray, which is in the 1930s, 1940s, a definition by Lowenstein was defined as a lateral curvature of the spine. And when you look at the history of definitions, it's really impactful now to understand how much we lean on our definitions to drive treatment. So surgeons were doing Harrington rods and pulling that spine to midline, and physical therapists were doing side bending exercises. So the definition has evolved. The Scoliosis Research Society is still focusing very much on using the X-ray to help them define, but I think there's an evolution in the definition in that they're recognizing the flexibility within scoliosis. So there's a mention here of if they side bend in the side bending X-ray and the curve goes beyond 0, then they will say it's a non-structural, but if it doesn't, it's a structural curve. So this lends to the idea of thinking about how even a structural curve, if you take it one step further, has some variability within it. So not all curves have the same flexibility, but moving on to another definition that goes a little deeper into the definition of scoliosis, the World Health Organization mentions the three-dimensional aspect to it, and it mentions the spine and the trunk and all the planes that are impacted. And so this definition has a really nice holistic way of mentioning the structural and the functional aspects that are involved in the definition of what is structural scoliosis. So SOSORT, which is the International Scientific Society on Scoliosis, Orthopedics, and Rehabilitation Team. So you'll hear me say SOSORT several times in this talk. But the SOSORT definition is a complex 3D deformity of the spine and the trunk, which appears in apparently healthy children and can progress in relation to multiple factors during any rapid period of growth or later in life. So this really drives how physical therapists, and I think also orthotists and doctors who have been coming to the SOSORT meetings, I think also are starting to recognize the impact of the soft tissue in how scoliosis may be impacted and the use of the body and how that could be a progressive factor in scoliosis. So both a structural and a flexible component. So when we look at the structural component, we're really thinking about the bones, but physical therapists, we're postural specialists, and we're really looking at how the body responds to the scoliosis and what is maybe being lost in the central nervous system in the process of the body just following the curve instead of maybe cognitively and then hopefully later subconsciously being able to manage the body around the scoliosis in a better way. So clinically, we will do the Adams-Ford bend test. We refer out if the angle of trunk rotation using the scoliometer is greater than 5 to 7 degrees. And if we have a referral that we already know is scoliosis diagnosed by the doctor, and we see the radiological outcomes, we will then look more specifically at the X-ray. What's the apex? What's the transition point in relation to the central sacral line to help drive our treatment? So I'm sure you all already are very aware about the anatomy of the apical vertebra and the multiple three-dimensional aspect of its deformity, obliquely, sagittal plane, and frontal plane. So this anterior overgrowth that we see, which causes this postural balancing that allows for that front aspect to be unloaded and with growth continues to grow, is this relative anterior spinal overgrowth that we are trying to limit the compression so that we can limit that progression during growth. So in addition to that shape having a negative impact on the growth patterning, we know that it creates a torsion, and there's multiple types of torsion. There's mechanical torsion and geometrical torsion. So we know that at the apical level, we have both this torsion within the bone, and then we have at transition points rotation between segments within the disc. The geometrical torsion is really what I wanted to highlight, and that is where through these torsional forces that are happening at the apical level, the spine will leave the axial axis and the spine will rotate and go through the body in a very characteristic way that we see the end result of on an X-ray that we call a Cobb angle. So it starts maybe with just wedging in the axial axis, and maybe with the Adams 4 bend test, you see it, but on an X-ray in this very first, move of the body from this idiopathic aspect that we get this wedging, which we're still trying to figure out, you'll not see a Cobb angle, but the structure of the vertebral bodies are wedged and they are at risk of progression. And once they go through this mechanical torsion, they will go into this traditional expected mechanical torsion. So we as physical therapists are very much thinking about what that path of torsion this apical vertebra is going through and how it's impacting the levels above and below, and also the transition points between different areas of the spine, upper thoracic and the lumbar, if we're just speaking about the traditional right thoracic. So Dubocet has a very important definition that we follow closely in the Rigo concept in our treatment thinking, and it's really deeply the source of what we use to teach and also teach other therapists and also to drive how we treat. So scoliosis is a combination of torsional regions joined by junctional zones. Each zone involves vertebra that are in lordosis, rotation, and deviation to the same side. The relative anterior spinal overgrowth contributes to more progression. The vertebra will go faster where there are tractions and slower where there are compressions. So the more deformity, the more torsion, the more compression, the more progression, and hypokyphosis. So this really is the vicious cycle that if you're doing anything with scoliosis, you know about the vicious cycle with Stokes, and how the pathology within the bone does impact the trunk and the soft tissue, as well as the nervous system, as well as the biomechanics. And really where I think physical therapists feel like we are making an impact in reducing the risk of progression of scoliosis is at the asymmetrical loading. By training a person about how the scoliosis is impacting their trunk, how it's impacting their posture, how it's impacting their body mechanics, and then giving them some resources and strategies to reduce those asymmetrical loads. So the goals of all types of conservative management are the same, and this list of goals comes from SOSORT, that international body of conservative management studying therapists, doctors, orthotists, and researchers. So our goals are to stop curve progression, to prevent or treat respiratory dysfunction, to prevent or treat spinal pain syndromes, to improve aesthetics via postural correction, include education to improve ADL and overall quality of life. So not to be provocative, but just to point out that the word Cobb angle is not in this list. Not that it's not, of course, all of us want to focus on the Cobb angle as it teaches us a lot through their growth cycle, but there are many other aspects of scoliosis that need to be addressed, and this is what scoliosis physical therapists are focused on. So there are other schools that are known through the SOSORT consensus, and you'll see many different titles here. I've highlighted the Spain, which is Dr. Rigo is our mentor. Dr. Rigo, his school is now called Rigo Concept BSPTS. And then the original Schroth method, because it's a very common term used in the research and also just common language, was originally from Germany. It started in 1920. It was within the family, and it grew throughout Germany. But actually, even in Germany, the method itself has been modified. It's been 100 years since the original Schroth method and their family. And with research and evidence-based changes, there have been modifications to all the methods, and none of them are actually the exact Schroth method of the original family. So ISST, when they do their training, I think their therapist will still come out and say the word Schroth trained. But I just wanted to make that clarification because I think there is a lot of confusion about the word Schroth versus Regal concept versus other practices. All of us have the same goal. So the goal of rehabilitation is centered around teaching the patient to achieve active correction of the scoliotic posture, which will facilitate other goals being met. Regal concept specifically is defined as a scoliosis-specific therapy plan of cognitive, sensory motor, and kinesthetic training for the patient to improve his or her scoliotic posture, in the assumption that the scoliosis posture promotes curve progression. Also, to integrate this training and to reproduce a new motor program when they're doing ADLs. So this is not something that a person can learn online quickly or in a few visits. It's something that takes much time for a person to learn and integrate into their life without so much cognitive thinking. So we are working on the flexible component of the scoliosis. So you can see this person standing at rest and with the 3D correction. And this is her actively thinking. I mean, this is more of a mechanical change in this moment, but the goal is this becomes more automatic. So we're working in 3 planes: horizontal, frontal, and sagittal plane to help this person with their correction. And the ultimate goal, again, is changing the homunculus, really changing the central nervous system using neuroplasticity. So Dr. Rigo reports that based on long experience and with the current literature, we cannot expect that PSSE will prevent progression during the riskiest period of growth around peak velocity in an otherwise progressive scoliosis with potential to go over 45 degrees Cobb. So we cannot recommend PSSE as an alternative to bracing, but as a supplement to bracing when bracing is indicated. And also he reports the treatment of progressive scoliosis is a constant and unpleasant lesson of humility, and there are no masters, we are all students. The learning for doctors, physical therapists, and orthotists is a long and often frustrating experience, which, you know, honestly, less frustration and more love, but there are your cases for sure. Okay, so treatment indications, we all PSSE, all types of PSSE go under the same treatment guidelines that were organized for us through the SOSO organization. And this paper is very thorough in giving us guidelines on taking assessment and making critical decision-making. There's a high emphasis on the interdisciplinary team. So when you see the patient and you collect your data, that you're connecting with the orthotist, you're connecting with your doctor and making sure that the plan of care is a match with the family, definitely having a heavy weight on the decisions that are being made. The main indication for all PSSE is adolescent idiopathic scoliosis present as an adolescent or as an adult. Other indications are congenital scoliosis, deformities of the sagittal spine. May be treated also with limitations to syndromic and neuromuscular scoliosis, postoperative scoliosis fusion, adult onset and degenerative scoliosis, and with training parents for the infantile and juvenile. Precautions are with spondylolisthesis, inflammatory diseases, osteoporosis, juvenile hypermobility syndrome, osteogenesis imperfecta, and major psychiatric problems. Contraindications would be a reactive scoliosis and a scoliosis that you're trying to treat during an inflammatory disease's onset or aggravated. The guidelines for treatment for the Scoliosis Research Society are a little bit more simple. They have observation, bracing, and surgery. So you see that physical therapy isn't really in the protocol of treatment. Curves that are less than 20 degrees tend to be observation. 25 to 30, I think it's 20 to 25 degrees are observation. Bracing is for patients between 25 and 40 degrees, and surgery is used for patients who are greater than 45 and still growing and maybe over 50 degrees. And there's more literature here in this book about the Scoliosis Research Society's screening methods and what to do with positive screenings. So scoliosis specific exercise, the PSSE that I keep mentioning, again, the goals. Specifically, after a physical therapist who has been trained in scoliosis specific exercises, most all of the PSSEs from the SOSORT committee or SOSORT group will be using the Rigo concept classification. The Rigo concept classification was developed because there was no classification for us clinicians who don't have access to just call an x-ray and just look at that, which is actually a gift. We get to see the patient live and moving and three-dimensionally. So this Rigo concept is a combination of both what we see in the clinic, looking at trunk imbalance, and the Adams forward bend test for the spinous process line and the rib prominences. So we have categories A, B, C, and E, and both this this classification is both for physical therapists and orthotists. And then we will look at the x-ray and we will confirm, does the x-ray match what we see in the clinic? And we really do look at the clinic before the x-ray, because who knows if the person is breathing in, breathing out, arms up, arms down. The tech told me to put my chest on the wall in front of me. So really there can be many factors in the x-ray that can knock off the transition point or knock off what we're seeing. So we always use this as a secondary to what we're seeing in the office. So we will then take the patient and explain to them, look at how your trunk is imbalanced. Look at this transition point on the x-ray and how this is the match that you're looking for. And then with the Adams forward bend test, looking at the prominences in the spinous process line so that we can then come up with a classification system. So in this case, this person would be a B type. What we do then is go to treatment. All curve types have the general principles in play, the 3D postural correction, and very closely associated the expansion technique, which is a form of auto correction or self-elongation, which I mentioned all of the disciplines will use, followed by stabilization of the spine using muscle activation, and then integration using what they are learning in the exercise, integrating in that against gravity and with their ADLs. We will use and access all planes and axes, so axial elongation, sagittal plane correction, and frontal plane correction. And in combination, when you work the sagittal and frontal plane, you'll get the horizontal plane correction involved. So this person is demonstrating to you standing at rest and then standing with self-elongation. And you can see just with self-elongation, she is getting some frontal plane correction. You can just see just purely with self-elongation how she has this translation in the frontal plane that occurred. It's this is an adult, clearly, so we aren't having the same expectations about the horizontal plane with this group. In a younger group, we're going to talk a little bit more about pairs of forces, working sagittal plane against sagittal plane on one side versus the other to help create a detorsional force about the spine. And again, the frontal plane, as you saw in this person from before, but this would be the frontal plane awareness that we would be teaching. Once they have this in a stable way, that they can make this postural correction, it's typically gravity assisted in the beginning or just laying on their back, not having to fight gravity. Once they have the correction without a lot of struggle, we start to introduce this idea that their breathing mechanics is a facilitatory aspect of the scoliosis, because you can see the scoliotic breathing on the left. The natural path of breathing is going to be in the path of least resistance. So the prominences are going to take the air. And what is not going to be able to have flexibility and stability are the areas that are not being expanded with each breath. So imagine 12 times a minute, you're taking a breath and you're facilitating that torsional aspect of the scoliosis. So once they've taken up the slack of their system, self-elongation, manage the planes, we'll start addressing, can you can you assess in your own body how your breath is moving within you? And can you start to modify with your breath from the inside out the stiffness and the struggle that you're having here in the front on the right, in this picture on the right, and or on the left? And over time, releasing the tissues and modifying. And actually in young kids, are we having the possibility of trunk reshaping because they are less, they're more mobile, they have growing to do? Can we change that over time? So here's some positions, like I said, kind of not in gravity. So this would be a B-type scoliosis. We have the person on their back. We're encouraging lateral expansion. We're encouraging the axial expansion. It's harder in this position for you to see the sagittal plane detorsional forces that we use. Here is another position, gravity assisted, that they're working on these same ideas. Prone on stool, another position, they're working on these same ideas. These tools that you see, a stool, a bolster, those are all just there to help them proprioceptively feel their body when they take a breath. Are they breathing laterally, or are they continuing to breathe in extension, creating that flat back, which is also promoting of more forces negative to what we're trying to do. Sideline, working against gravity at that primary curve, very challenging position. Sitting and standing, very challenging against gravity. They have to really understand their bodies. There are some cases that we can do some overcorrection, but this picture on the right, this is an adult. We're aiming towards neutrality to the best of their body's ability. So PSSE research. One of the major criticisms of PSSE research, or actually the management of PSSE, is there hasn't been enough large-scale randomized controlled studies to support its efficacy. There are a handful of randomized controlled studies that have been completed. Many of the literature reviews, have been completed. I did send out a 4-page reference list that I tried to bold the randomized controlled studies for you. I'm not going to have time in this session to go over all of them, but I hope you can use that for both the literature review and the randomized controlled studies. One of the things that I notice as I'm reading through these articles is the outcomes are really focused on the Cobb angle as the primary indicator of success, rather than what the PSSE treatment goals are, which is neuroplasticity, postural control with ADLs, pain management, quality of life, and breathing mechanics. The SRS has currently funded a PSSE study, and it's underway, and definitely more studies need to be done. I cherry picked a few studies for you. They're just with this time constraint. I can only do a few, but this is an older study, and these articles are all the really grandfathers of PSSE. These articles are really case studies, maybe a couple consecutive studies, but they're all lower level quality in research standards. But what they were looking at is what were the outcomes at the end of treatment for those who did exercise or did not do exercise. So anybody that was indicated to have a brace was able to wear a brace if they wanted to wear a brace. But what you can see here is the group that that did exercises showed more improvement than the control group that chose not to do exercise. Dr. Rigo and Dr. Weiss did a retrospective that reported that conservative methods of treatment with outpatient physical therapy on an intensive basis and the application of highly corrective braces are effective in reducing the prevalence of surgery in patients with AIS. Ottman did a study in 2005. It was a prospective study. It had 50 people. They did exercise 5 days a week, 4 hours a day, for 6 weeks, and then they had a home exercise program. What was measured was Cobb angle, vital capacity, muscle strength, and they measured these at 6 weeks, 6 months, and 1 year. And in the study, they found that the Cobb angle did decrease and vital capacity increased. Another literature review by Dr. Negrini and Dr. Fusco, also in 2011 as a follow-up, report that all of the studies confirm the efficacy of exercise in reducing the progression rate, mainly in puberty, and or improve the Cobb angles around the end of growth. Exercises are also shown to be effective in reducing brace prescription. In our literature review articles that I sent to you, there is a more updated Cochrane review. So you go ahead and, you know, continue your reading and studying with that newer thing. Future learning for you. Rigo Concepts educational program is not just about scoliosis specific exercise, which it kind of sounds like it after my talk. So I just wanted to share that we also have courses for orthotists, so that we have a bracing component to our school and also scoliosis management. And for those of you who are interested, next year there will be an online course for medical doctors through the Rigo Concept educational program. I encourage you to look up the SOSORT website. On there, you will see a tab for the education. We also have webinars. We have one coming up September 21st, and there's an annual conference. The next one is in Dubrovnik in May of next year. And then, or April next year. SOSORT, SRS website is a phenomenal resource. They also have quite a few webinars that are free. And the SRS conference that's coming up in September is in Barcelona. And I wanted to highlight this one webinar for you that was in November of 2020. If you go to the SRS website, you have to go through a couple steps because you have to register for free on this brightspace.com. But this webinar is for free, and it was a really well done webinar with Eric Perrant, who is a researcher and a professor, and he went through all the literature, maybe a quick review for you. I actually took some of the references from his talk and put them on my reference paper. So if you're a better listener than reader, for some of that information, you might find that helpful. So thank you. I have no idea how long I talked. But I am willing to take questions after now or after Tarju speaks. And I just wanted to say, if questions come up even after this time, that feel free to reach out to me. Rebecca is the Asian Pacific Regional Manager for Rigo Concepts, so feel free to open up any questions to her as well. She's here, and thank you, Rebecca, for being here. And Gary is our business manager, so you have access to us in many ways.
Superb. I think the talk was completely on point, Amy. We were very, very impressed because we didn't know what to expect from the talk. And this, comes on the background of us looking at scoliosis from a very different lens. And you really kind of opened up a third dimension or a fourth dimension in our heads. Amit, do you want to take over? Do you want to take questions now? Or do you want to do it?
I think we will have a question for Amy just now. It was a very nice concept, an eye-opener for us that exercises can be done. Because more or less what we are doing is, if it is less than 25 degrees, we just keep observing. From 25 to 40, we just do bracing, but we don't advise as such a lot of exercise programs. So that's the point. So can you just tell me what are the exact exercises program that you give to the patient, for how long they have to continue? Because this is the whole progress. The scoliosis is going to progress from maybe the adolescent age group 12, 13, and it will just go on till 17, 18. So till how long that you are going to observe this patient and start doing and continue the exercise program? Can you just elaborate on that part?
Yeah, I think, well, again, it's an art, because if you would have asked me this as a new student, I would say it's going to take me 6 months to train a person to do and to understand, because I was finding my words and finding my way. Now I can probably in 16 hours be able to have a person be independent of me from a perspective of doing their home exercise program by themselves. But very important that I insert myself with follow-up visits. So if a physician, I follow the plan with the physician. So if a physician says, I want to see you in 6 months for a follow-up, I'll say, then I want to see you for 1 hour for a assessment at 3 months. If the doctor says, I want to see you in a year, then I say, I want to see you probably in 6 months. So I will follow in between so that I can catch things. So I can say, you're outgrowing your brace, you need to go back now, or things like this. And check in on it's also good accountability that they know that they're coming back to see me, to keep them accountable to their home exercise program. Okay. And there is a moment of time when you tell the person, this is for life. This change of the central nervous system is something that you have to stay on top of, because the structure will win. The structure will win the race unless you stay on top of your retraining. So it is something that they can learn in 16 hours that they will do for life.
Dr.
I will
Menon had
stop
a
seeing them
question.
when they're done growing.
Dr. Menon had a question followed by Pankaj.
Yeah, Amy, that was an excellent lecture. I
Thank
just want to ask you two situations where these exercises might be applicable. Is it applicable for shoulder imbalance? If you have a shoulder asymmetry, is that applicable? That's question number one. And you mentioned post-operative situations where you could use it. Could you use it for trunk decompensation as well? That sometimes happens when you do things like selective thoracic fusion and all that. Is it applicable?
Yes. Okay. So for the shoulder is imbalanced because the scapula is being impacted by the rib rotation. So yes, this is a consequence, an outcome because of the rib rotation. So yes, it's part of the treatment that we address that shoulder imbalance. And second, with the surgical post-surgically, I would say yes, for sure, we can help manage post-surgically, but more important is that they come pre-surgically. Even if they're a surgical case from the get-go, you say, okay, you have growing left and you have 45-degree curve. We know that this is a surgical case. But let us give you education about your posture before surgery. Let's get you understanding length, strength of your body prior to surgery. So when they come out of surgery, they don't use the transition point and they don't get the junctional zone problems. But also after, just as a reinforcement is important. So pre-post surgery, it's actually a very hot topic in PSSE right now.
Yes, Dr. Pankaj.
Hi, Amy. That was an excellent talk. And
Thank
I
you.
have two questions here. Like
Yeah.
right now, I'm talking about a 40-degree curve in a late adolescent, and we know it's going to progress as she goes into the adulthood and things like that. So how do you prognosticate those patients, and how do this PSSE come into place? One and two, is the regimen different from for adults when compared to adolescents?
Yeah. Okay, so yeah. I remember when I first moved to Boston and I met with the doctors at Children's and I told them what I was doing. All of a sudden, I had patients coming to me that were Risser 0 and 45-degree progressive curves. And I was like, oh boy, we've gotten past the ability of what I can help. So the important thing is early onset, really doing those screenings and getting the people before they've gotten to 40 and 45. So really, we love to see the 20-degree curves. We love to see 15-degree curves. We want to take them off of your schedule. They don't need radiation. We want to get them to know their bodies and avoid the brace, so this would be ideal. If they have a 40-degree curve and they're progressing, I would still, we give it your best shot. We still want to brace. We still want to do exercise and see if we can stop it there, because many people can live a very nice life with a 40-degree thoracic curve and really do just fine as an adult. So that would be a great win. But then adults, yes, we cannot treat adults the same. It's if I can say the word watered down, it's a modified version. We cannot do as much aggressive treatment, but it's still very valuable. It's the center of my research is adult treatment and the modification outcomes.
Thanks.
So
Yeah.
one more question from my side. You see, we in India, we are not that much, the patients are not that much motivated for the exercise program, to be very frank. So the exercise has to be continued, as you said, 4 hours per day, 5 days in a week.
Oh, no. Yeah. Okay, go ahead. Sorry.
So I was just thinking
No.
whether it's possible or not, because it's
No.
not. So
Yeah, this is not realistic. No, so this was that study. It was aggressive. It was an intensive, we call it intensive. That was an intensive program. So our recommendation is 20 minutes a day, 5 to 6 days a week, 20 to 30 minutes a day, 5 to 6 days a week. And let me tell you this, I don't care if it's scoliosis or an ankle sprain. If the patient doesn't feel like it's making a difference, they're not going to do it. So I don't blame a person to not do exercises that they don't feel a difference. I do not have any compliance issues at my clinic at all, because what we're training, the patient feels is making a difference, and they crave it and they want to do it. And when they miss a day, they don't like how their body feels. This is the difference.
Great.
And that one last question from Dr. Ajay, which I think is very practical. Can you do these online with Indian patients?
So it's not advised. It's it's many people say, why don't you just write a book, or why don't you do this online? I mean, it is a very intimate relationship that you create with your patient, hands-on, feeling them breathe, coaching them, having your hands teach them. Do you feel how your ribs are expanding? Do you feel how your body's reacting? It's if you have had a person visit you, you've done 5-10 hours of treatment over 2 months, something, and they go to college, can I visit them in their dorm room online and say, hey, let me see how you're setting it up. Let's talk. They already have foundation. Yes, I can do this. But from the get-go, this is tough.
Awesome. Yes, Rebecca, you're muted.
Yes, I was going to say that's why we have courses, and we're very, very happy to come and train your physiotherapists. So I just was in Malaysia running a course training a group of physiotherapists and doctors there a couple of months ago. I was in Singapore the 6 months before that, Japan next year. So if there's a group of physical therapists that you have, and orthotists or doctors that are interested in training, then please just put the word, and we'll come to support your local practitioners.
That's awesome. That makes a lot of sense, and we'll open it out to our physical therapy bodies then. Awesome. Thank you, Rebecca.
Thank you.
Amit, you want to take this forward?
Yeah, sure. So I think we just not waste our time, and I'll ask Tarju to present her talk.
Sure.
Over to Tarju, please.
Give me a minute. Okay. Thank you, Dr. Amy, and thank you everyone for putting this together. This is awesome, and it's from India, so I love it. And let's get started with a case. So I'm going to present about, just a minute. My slide is not changing. Just a minute. Okay, yeah. So I'm going to talk today about my wonderful 12-year-old, almost a 12-year-old, who I started seeing when she was 11 months old, and I started seeing her in early March in 2023. And I know Dr. Amy just stated that Cobb's angle is not exactly what we are always looking at, although it makes a difference. And this is one of the most objective evidence of, how the treatment worked. But there are many other aspects that we're going to, of course, look at, including how the quality of life of the patient changed before and after. How much did the endurance change? Let's say the patient wanted to walk for a mile, and she was not able to after 2 blocks just because, she started complaining of having severe back pains, So that's what we're going to look at. But this is one of the most evident objective information that we have, like how the treatment worked. So when I started seeing her, the patient's RESA score was 45.6 right thoracic, and she had left lumbar 21.2. And in amount of 4 months, we were able to change it to the right thoracic that was 34.6 and left lumbar 13.2. This was really challenging for me because it was early on after I just got trained. I literally just got certified, and I was in panic. I was like, how am I going to do this? Just as Amy said, I know Cobb's angle is not what we're looking at, but sometimes that's the motivation that comes to the parents, especially who are not seeing the quality of life changes in the kids. The kids are experiencing it, but the parents are like, okay, did the angle change? Because our doctors recommended surgery. So now that she was okay, she was good, and even the parents were happy. So I have the x-ray just to inform that it does also work on the Cobb's angle, even if we are primarily not looking at that. So I will just go ahead and quickly take you all through the tests that we did. First one will be the plumb line. These are the most important ones, along with the other, the general orthopedic assessment that we do with the kids and go through their radiographic information and stuff like that. But this is the plumb line, which starts from the C7, and there's this line that we draw from the middle of the C7, and it goes all the way down, and we compare it where it falls from the central sacral line. So for this patient, the central sacral line, the C7 plumb line was falling to the right of it. And we also did the Adams forward bend test in seated. And this is the posture of the patient in standing and sitting. So in standing, according to the Grigo classification, I would classify her as being a 3C kind of curve, where her pelvis is shifted to the left and she's weight bearing a lot on her right side. These are just, the big picture that we're looking at, but there are a lot of different things that we need to consider while classifying them. With a certain kind of putting them in a certain kind of group before, designing our treatment session. Dr. Amy did talk about this. So these are the general principles of the BSPTS school. So we always start with a 3-dimensional postural correction, which comes with a combination of making the changes in how the pelvis looks, rotating, derotating it in different planes, having equal weight bearing on both feet, and then getting that axial expansion through which we can get the 3-dimensional postural correction. And the expansion comes in all different planes. That is the sagittal, the frontal, and the transversal plane. And then once we have that, once the patient is in the best posture, we do a lot of muscle activation technique. The easiest example of muscle activation would be when we breathe in, we are expanding in all 3 planes, all 3 axes. But when we breathe out, it needs a lot of control for the one who is going through scoliosis. It needs a lot of control to not get back into that collapsed posture. So what we are looking at here is having the patient control that posture, maintain that posture, and hold it while they're also exhaling, if that makes sense. So, and then building upon that, and then as Dr. Amy said, and brain is favorite part of what I do. So it's all about changing the homunculus in the brain. It's about changing the pattern of how they move. It is about creating a new muscle memory, and how Dr. Rigo likes to tell it, new normal. So that's what we are focusing on. And then once the patient is more aware of everything that he or she has gained, we take them to the next step, which is integration. All these 4 principles, they will go hand in hand. They build upon each other. Integration is one of the main parts, because that's what we are looking at, as good as sitting for a prolonged amount of time in their school, or being able to give their best posture when they're working on different sports or whatever they are doing, in their day-to-day life, as good as how to sleep, or what should be the ideal posture, or what should be the ideal posture while, picking up things from a shelf or from the floor, or, everything that covers it. It is going to come from the integration. If we are not working on that piece, the above 3, they're not going to make sense. So that is going to be the main piece of training the patient, that is integration of the achieved posture in their ADLs. These are I know Dr. Amy spoke about this. These are the 5 treatment postures that we, especially the level 1, start to work on. These are all spinal unloaded positions. So we are giving the spine enough space to elongate. And these are the 5 basic positions. That is the full or semi-hang. As you can see, the patient is, hanging on the bar. And then the next one is the prone on the knees. There is supine position, there is sideline position, and there is one which is prone on stool. Sorry, I don't have a picture for that, but we also work on that. So what we do here is in the spinal unloaded position, we are using the gravity. We are using the rice bags. We are using belts to make them come into the best possible posture. And then once they are into that, we are also working on, as we said, the expansion and the muscle activation in all these different positions. Sometimes we're using muscle activation, such as, we are doing isometric shoulder tractions. We are working on pulling and pushing of a bar or the floor, and we are working on all those muscle activations when they are in these particular positions. We can also use a lot of mobilization techniques, especially when they're prone on their knees. So, just mobilizing their rib cage and their spine to get the best posture. Now that, because in this position, we are going to traction the spine out, we are going to elongate it as much as it can to its full capacity. So we are going to get a lot of space to do also those mobilizations. So that's what we also work on, along with a lot of different things that we do work on. And here comes the best part of it, the functional training. It is my favorite. And as you can see in the picture, the left one is the day one of that kit, and right one is after we did a lot of, postural training, applied all the Rego concepts on her. And this on the right is not me telling her to do anything. And it's not even her doing anything. She was just effortlessly doing it. She has been sitting like that, So that's how it changes how the kid is thinking about, or how the kid's brain has changed in a certain way. And that brings them to their new normal. So I asked her, I was like, are you making any changes to it, or is it just happening? And I saw it building up, for a couple of months, and this is what we got. So it really changes, and we are posture experts, as Amy said. So yes, we are working on the posture. So if you can see, I think Dr. Nene asked this question about the shoulder asymmetry, or was it somebody else? I don't remember.
Yeah,
But
doctor.
yes. So as you can see here, towards the left, we are also working, you can see the difference between the scapulas. You can see the difference between how the shoulders look. You can see how the weight bearing has changed from just that asymmetrical loading of one side of the head and the spine, you see, and now she's correcting that pelvis to bring it to a more neutral position. So we are working on all those things, and now this is her new normal. So that's what, the change was. Along with that, I tried to do some, maintaining this best posture and giving her more of, come across the more realistic expectations. So it's like we worked on squats, we worked on standing marches, we worked a little bit on the treadmill just to see like if she's maintaining her posture or not. Because obviously I'm not going to go to her school and watch her walking. So I was like, okay, let's try the treadmill. So we did that. So yeah, you can see like how wonderfully the patient has changed the way she looks. That brings me to the end of my session or end of my presentation, but I just feel like what has helped me, the key takeaways from what my treatment session looked from those 4 months, is the maximum benefit that I see, because she's a teenager, she goes to school, she's one busy person, more than maybe the president of US, she has to do this, she has a list of things to finish up. So I was just able to see her once a week for 1 hour sessions, and the rest came from her being adhering to the home exercise program. She was on it, and the parents were on it, and she was like, more because she wanted to wear fancy clothes, and she was like, what about my posture? I don't look that good. And then of course, with it also came a lot of trouble with breathing, also came a lot of trouble with headaches, neck tension, all those things. And of course, they are doing their assignments and stuff. So she has a busy life, and we were able to ease her through those, day-to-day activities. So I think that is the key takeaway. Like any patient, you have to make sure that they are adhering to their home exercises. And it comes only once you feel confident that patient is going to be able to do it, or else it can really go wrong whatever they do. So I always tell them to, send me pictures or videos of what they're doing at home to make like, their own tables, like, okay, this is what we're going to work on, because Obviously, the patient is not going to be able to work on all 5 positions in just one day. So maybe spread it out to 5 days a week and work on whatever they can. If they're really tired, just do the hang, but do something, then nothing. So that's what we worked on. And then I feel the patient was, at least we were able to improve the quality of life of that patient. And as you can see from the X-ray also comes the evidence from the X-ray and other objective measurements such as, her breathing or her vital capacity and things like that. So yeah, I think it makes a huge difference, and all thanks to Amy for for training me in such a wonderful way. So yes, and for you all to give me this opportunity to speak. I hope this gives you a better picture of how the real case scenario looks like.
Thanks, Tarju. That was great, and it really, gave us great visuals. So this kind of, like I said, opens up another dimension in our, in our mind. So I was curious to ask you an uncomfortable question. What's the failure rate? Like how many patients that come into your clinic, you would think
Failure,
that, well, this is not working for me, and this is not working for them.
right.
And do you have any specific triggers that are, pushing them towards a failure, barring,
For
barring
sure. Yeah,
consistency?
for sure. I think for me, Amy has a lot of experience doing this. For me, I would say, I'm limited when it comes to my real life experience, not in the terms of like, mostly number of patients that I see. I just opened up my clinic a year ago, and that's when I started seeing really a full caseload of, too many scoliosis kids. Especially because we are talking about the adolescent. I think they're really, really worried about how they look. Once they get the results, I have seen they kind of give up and they're like, okay, at least that is what I would say in my experience, for them to come to me and this, let's talk about this patient. Like I have not seen her after a lot. Like I talked to her mom, but I have not literally seen her because they travel from a long distance. It's like, she comes from 1.5 hour distance because there is no other trained therapist in the area. She comes, and once she got this x-ray, she was like, oh, you know what, I'm doing great and I'm just going to do the home exercises. So I think, and it's great if they can continue doing it, but mom did tell me that she's not doing very good with her home exercises. So I think that's when I struggle with, getting that connection. Maybe I don't know what's missing. Something is maybe. Um, but yeah, I feel that's when I would see that. And I also see a lot of patients with neurologic involvement, like spina bifida. I see a lot of cerebral palsy. So for them, I would say the cognition is not enough sometimes. Not with spina bifida, but of course with cerebral palsy. And I don't think that is one of the indications to treat them with this treatment. So I don't know if I really answered your question. What would you say, Amy, about this?
Well, I saw Rebecca unmuted too. I'll say something quick because I think
Yeah.
Rebecca has something
Yes.
to say. It's
Yeah.
really hard to answer your question because
Yeah.
each patient, I think of them as like a finished product a little bit, like of many ingredients. So depending on the brace, depending on the compliance, depending on if they're a severely progressive curve or not such a progressive curve. So there's so many variables that it's hard to give you that answer clearly. But I would say if a patient has a well-made brace and exercise, I'm not seeing progression. There are cases, I would say maybe 1 to 2 per year of my adolescent population that the curve type is not responding to bracing and exercise.
So I think the
It's more
takeaway is that
rare.
everyone will benefit in some way or the other, and the level of benefit really depends on where you're starting from and how much effort you're ready to put in. There was another curious question from Dr. Arjun, who's one of our faculty. Are there any sports recommendations which you especially encourage as supplementary activities? Like, do you encourage them to do yoga, swimming, gymnastics, racket sport? Either of you could take the question.
The current research says that being active is the most important thing, and you want people to be doing what makes them happy. So if you say you must swim and they hate swimming, they won't be active swimming. So the most important thing is I encourage families to find the activity that their kids love and have them do that thing. Really only if you're doing extreme number, like Olympic gymnast number of hours of gymnastics or pounding on your body, are you going to have the negative impact that exercise can be.
Awesome. Pankaj, you have a question? And then
my question was very similar to what you just answered now. Tarju, it was an excellent talk. I'm just going to again ask you, are there any alternatives in case the patient has compliance issues or he's not able to take up these exercises because of financial issues? You know, what particular sports would you ask them to take up in case they are not able to carry on with your regimen?
Well, I'll say my favorite is rock climbing, but I'll let these other therapists speak.
I mean, Rebecca, do you have anything?
Oh, I was just going to say exactly what Amy said earlier. Any activity has been found to be better than no activity. So in line with what their passions are, I think there was that big study out of Italy that assessed, oh gosh, it was a retrospective looking at well over 1,000 participants. Amy, you might remember, and they looked back at adolescents, and my understanding is divided them into those who did less than 3 times a week of any type of exercise, and the other group were 3 or more times a week of any exercise. And I think overall, the ones that were doing 3 or more times a week of any exercise had less progression. So that's just interesting, and I believe there's the sub-analysis going on, or maybe it's concluded, but any exercise 3 or more times a week, I think that's right, Amy. But also just in supporting the person to be doing the exercises at home. I mean, I do a lot of voice recordings. When I have the person learning initially in with me, I'm recording me coaching them with the exercise. So when they're in their early days and they're going at home and they're by themselves, they can press play on their phone and they have my voice talking them through how to set up and actually then get going with the exercises and what to think about. So I'm there with them, and they know there's a start and a finish, and that's quite invaluable. But also with the bringing it into the integration. So setting things up like putting a sticker on the mirror where they brush their teeth every morning and every night, as a reminder for them to sense the activation in their body, so they're not just hanging in their curve. The idea is we're trying to get a flow on awareness that they're just lifted up in the direction of correction. And I know we say the word correction, but we're not thinking about it in the same way as you guys, where you're thinking correction is straight. We're thinking of the direction of correction, which is the direction of drawing them up out of the way that the scoliosis is going. And in that way, we can lessen the strength of the direction of the scoliosis, and the factors of we're just hanging in it makes sense that can be a factor that leads, encourages it perhaps. I sometimes describe it to my clients as, if you're a boat and you've got all the sails up and there's a steady wind going and taking you to scoliosis land, okay? And if they're a more progressive case, it's a really strong wind, and we're going to need something like a brace to be trying to steer the direction away. And if it's, not so highly progressive, or whichever stage they're at, they're on this path to scoliosis land. And what we're trying to do is teach them these maybe cross breezes, to just be lessening the power that is steering them to the scoliosis, and just trying to influence that and just keep it, away from that as much as we can. So Yeah.
Amit, you're muted.
Yeah, so I think Dr. KV had one question.
Yes, again, a very impressive talk. Thank you very much indeed. My questions were twofold. First of all, it's very obvious from the images that you presented, the trunk symmetry has significantly improved from the pre-treatment to the post-treatment. But the first question was, do you have any measures for trunk symmetry before and after in terms of shoulder levels, scapular levels,
I can send,
symmetry,
yeah, I can
pelvic
send
levels,
out.
etc.?
Yeah, sure. I can send out. I had just had 10 minutes. I was able to just share what I was able to cover within those 10 minutes, but I do have, the measures. So if you want, I can share it with you all for sure.
Okay. And the second question was, again, you mentioned that a lot of patients in your practice are disabled by back pain and neck spasm and neck stiffness and neck pain and things like that. That's very interesting you said that, because my deformity practice is almost entirely adolescent idiopathic scoliosis. We operate between 40 and 75 patients every year, and we treat a whole bunch of them non-operatively. And it's exceedingly rare in our practice to see a scoliosis girl having a back or neck pain as such. Some of them do have discomfort. Some of them have, at the end of the day, they complain of vague aches and pains in parts of the body, which is possibly because of mechanical imbalance or the muscle asymmetry and things like that. That's understandable. But I have yet not seen a patient, at least in our population, AIS patients complaining of back pain or neck pain, disturbing their quality of life. Their quality of life is largely related to the cosmetic impact of the deformity. They find it difficult to go around and play with other children of their age because of their body image and their awareness of their body image and things like that, but not back and neck pain, at least in our population.
I'm
Okay.
sorry, I have to go. I have to drop. Thank you too
Yeah.
for staying and taking over, but I have somebody here to see me. So it was very
Yeah.
nice meeting you all. Have a nice
Yes.
evening.
Yes.
Thank
Bye,
you,
Amy.
Amy.
Bye.
Thank you for being with us.
Yeah, thank you. Bye-bye.
Great. And
Hi.
maybe at this point,
Um,
yes, Rebecca.
Yes, I might just have a comment about that. And I agree that if somebody says that if there's a teenager who says they have pain, I don't think, oh, they might have scoliosis. I totally agree. They have like any adolescent, scoliosis or not, might have a pain like any person. Anybody who has a spine can have a pain, right? So yeah, I kind of approach it and explain it that if your spine is where it is and there's not the spinal support and you're just hanging and winding up, or the biomechanics aren't right, then that can be pain provoking. But scoliosis itself, yes, in a teenager is not necessarily linked with pain. And I hear you with it's very often, especially what you would be seeing with the very pronounced curves, that's where it's going to be impacting them choosing to not participate in a lot of things. So yeah, I mean, some people have pain, and we manage that. And I guess we see a lot of that. Oh, well, look, that's what can bring anybody to a physiotherapist, whether they have scoliosis or not. So, yeah.
Yeah.
Awesome.
I would say for this particular patient, I would answer your question. So she has severe tightness of her bilateral traps. So maybe the neck pains because of that. She is also a competitive gymnast. And she is one girl, if she puts her head into something, she would just make it happen. And she was an over enthusiastic gymnast. So maybe she was putting a way more stress than she is supposed to be with that 45 degrees of curve. She was at the period of max growth. Research went from 0 to 1. So maybe that's why. And sometimes I just feel like they build on that, and they sometimes might be exaggerating. I don't know, because they're typical teenagers, they want the attention, so they might be exaggerating. But also we need to be mindful about how the school system is here. They are sitting for 1 hour in one class and they don't stand up for that 1 hour. So maybe that is she's always in that bent posture. And then she was going to the traditional physiotherapy, and she did it for about 6 months, where she was laterally bending her spine without giving any three-dimensional axial expansion to her spine. So she was just constantly doing that stretches and that side bending. And that could have led to where, she was experiencing those kind of pains because it was maybe crushing her spine even more. So that's at least but it's subjective, so we don't have a definite measure of that for sure.
Awesome. I think for want
Awesome.
of time, Amit, should we
Yeah,
wind
yeah.
this?
So we just wind it up, and we had a very nice discussion from Amy, Rebecca, and Tarju. I heartily they have given a very nice talk and given openness into our system, where we have to also focus on the exercise therapy along with the brace. And I thank all the three speakers, and over to Abhay for our next program.
Yes, of course. Thank you all three of you all, because you really put this in a very succinct and a very user-friendly manner for surgeons. So, and as a lead up to to the future, we hope that you stay engaged with the society, because we're going to need your help on many counts, and maybe this could open up an opportunity to have a physiotherapy seminar in India for just trying to train our therapists also. We have a bunch of great therapists working with us, and all they need probably is some direction. So thank you for that. And Amit, thank you for getting this together, because it was your handiwork and the topic is of your choice, and I think this turned out beautifully. Thank you, Jesco, our industry partners, for providing us with great implants for surgery. So and sponsoring this session also. And I think most importantly, because of the interest that this one has drawn, we are going to move to the next topic also on this in the same bracket, which is bracing and scoliosis. And the tentative date for this is the last Thursday of the next month, which is 26th of September. Again, about the same time, and we hope the same speakers also are engaged, aside of some other people. And this is going to be after the SRS meeting in Barcelona, where many of us will be there. So maybe we can meet in person before that. And thank you, audience. And of course, thank you to the members of the Pediatric Spine Academy. Until next time, namaste.
Namaste. Bye.
Thank you so much. Thank
Bye-bye.
you.
Thank
Bye-bye.
you.
Yes.
Thank you.
Thank you. Bye-bye.
Bye.
Thanks for having us. Bye bye. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Thank you.
Take care.
Yeah. No.